So today we have Dr. Diana Martins Welch. She is a palliative medicine physician at Northwell Health, and she is also the director of Northwell Cancer Institute Supportive Oncology Program. She is a board certified internal medicine physician, as well as a hospice and palliative medicine physician. She concentrates on global symptom management for the patient with cancer, working collaboratively with various specialists to provide patients the most comprehensive care. Dr. Martins Welch has a particular interest in studying the effects of early palliative care for cancer patients in medicinal cannabis for management of symptoms. The cannabinoids, I'm probably pronouncing that wrong, THC and CBD will be discussed and their medicinal effects reviewed. She will present the conditions that medical cannabis is most commonly used for while reviewing some of the data that supports its use. The New York State Medical Cannabis Program will be discussed in detail. So with that said, I will hand it over to Dr. Martins Welch, and she will do her presentation and leave 15 to 20 minutes at the end for questions. If you do have questions that you think of beforehand, please feel free to put them in the chat.
Thank you so much, Carly. I'm going to share my screen now so I can put the PowerPoint up. And I'll put this into share mode. All right. And that looks okay? Yes. All right. Fantastic. All right. So thank you. Again, I'm a palliative medicine physician at Northwell Health. I work in the Cancer Institute. So I take care of cancer patients day in and day out. However, we do know that cannabis does help for a variety of different disease types. So I'll just say that at the outset. My focus is cancer. So I will talk a lot about the symptoms to do with cancer, and I'll also touch on other aspects that cannabis is used for. So the title of my talk is Medical Cannabis, What We Know and What We Still Need to Know. And so I hope to provide a good overview, a foundation of knowledge for you all today. I have no disclosures. So what I want you to take out of today's talk is to understand some of the history of medicinal cannabis. I want to go over the basics of the human endocannabinoid system because they provide a basic understanding as to why cannabis works in the human body. I'll review the major phytocannabinoids and try to teach some of their medicinal properties. And I'll also leave time to review the New York State program, especially as it's sort of in flux right now as we embark on the recreational legalization as well. And I do like to leave some time for questions and discussion at the end because it tends to be a pretty engaging topic that people have questions about. So as of earlier this year, this map shows that 37 states have legalized medicinal cannabis. And I want to say, I don't know, maybe another 13 or so, including us in New York, have approved it for recreational use as well. So we are shifting towards, most of the country now, approving it at least medicinally. Whether or not healthcare providers agree with it, it is certainly something I tell clinicians I speak with. It's a topic that you should know about, whether or not you believe it's a medicine. So what is cannabis? It refers to a genus of flowering plant. It's native to Asia, and it has 3 subspecies. You may have heard of the term sativa, indica, ruderalis. Sativa and indica are the 2 subspecies that are utilized for medicinal use. There are over 400 chemical compounds that are produced by the cannabis plant. 65 of these are unique to it, and these are termed phytocannabinoids, phyto for the term plant. And so the phytocannabinoids of most therapeutic interest that I'll be focusing on during this talk are tetrahydrocannabinol, which is otherwise known as THC, and cannabidiol, otherwise known as CBD. All right, the biological components of cannabis are listed here on this slide. So we have the major phytocannabinoids, as I discussed already. And then we also have minor phytocannabinoids. And these you may hear if you go to a dispensary, they may start talking about CBG and CBN and these other types. And so these are called minor phytocannabinoids in the sense that they're not in, I guess, as much concentration in the cannabis plant, but also we just don't know enough about them. There's more anecdotal and speculation as to what they might do, but not as much research done on these cannabinoids as of yet. There are also terpenes. Terpenes are what are implicated with the aroma of cannabis. So if you walk into a room or you're walking on the street, you can smell marijuana, and that's what you have to thank the terpenes for. That's what the terpenes do. And they are also used medicinally. So, you know, the more mature programs, you know, like in Colorado, for example, one of our older medical programs in the country, you will find products that may have, you know, more linalool or limonene or alpha pinene, because it may do this, that, or the other. That's more complex medical cannabis. That beyond my scope of knowledge even. We have carotenoids, fatty acids, and the list goes on. So this is just important to know that there are a lot of different components that are extracted from the plant for medicinal purposes. So the two phytocannabinoids, as I talked about, and I listed here their chemical compounds. I list this slide because it's important to note that in the raw plant form, the THC and CBD are actually in their acidic forms. Once they're heated above 105 degrees Celsius, they are in their active therapeutic form. So that's why you see these products typically tend to be heated. You know, if people are eating it in edibles, it's baked. You know, if people are smoking it, it's, you know, it's combusted. So just to think about you know, how we are ingesting it. Although there are schools of thought that will eat it, you know, put it into smoothies. There is some value to the acidic form as well, but the form that we're talking about medicinally tends to be the heated form. So these phytocannabinoids that are derived from the plant act when we ingest it in one way or another in the human body. It exerts therapeutic benefits, and it wasn't really understood up until the 1990s when the endocannabinoid system was founded in Israel in a laboratory. And that's when they realized these phytocannabinoids from the plant induce pharmacologic activity because there's receptor and non-receptor mediated effects on this system that has been termed the endocannabinoid system. So I'll talk a little bit more about that in a minute. I just want to turn to the history for a minute. A lot of people view cannabis as sort of this new drug, but it's anything but, right? It dates back as far as ancient China. It was used as a popular medicine called ma. And it made its way to ancient Egypt. It was used for things like glaucoma and inflammation, and then ancient India, and then ancient Greece. More recent history, in the 1500s, the Spanish brought cannabis to the Americas. Irishman Sir William O'Shanassy was one of the earlier researchers on cannabis, where he focused his efforts in India. And in 1850, the United States Pharmacopoeia classified marijuana as a legitimate medical compound. So it was found in many medicines. It wasn't until the 1930s when there was this anti-marijuana campaign brought about. And that actually resulted in the Marijuana Tax Act, which banned cannabis use and sales. And then fast forward to 1970, the Controlled Substance Act made cannabis or marijuana a Schedule I substance. And what Schedule I designation by the DEA means is that this compound has no medicinal value and has a high risk for abuse. And it still sits as a Schedule I substance today in 2022, if believe it or not. And so we have Harry Anslinger really to thank for it, because he was the first director of the Federal Bureau of Narcotics in 1930. And he's the one who really launched this vigilant campaign against cannabis. And I try to keep to the term cannabis because marijuana actually was rooted in very racist terminology. So Americans sort of, called it what the quote unquote Mexicans called it marijuana, to sort of maybe, to make it more foreign sounding and say, well, this is something we need to be concerned about because the Mexicans and the Black jazz musicians are using it. So that's something that a lot of people don't realize. There's a lot of racist roots behind the propaganda against marijuana. So let's shift back to the science now. So I want to talk about the endocannabinoid system. So what this is, it's a network in the nervous system that regulates neuron signals. And we naturally produce cannabinoids that are called endocannabinoids. So as you remember, I mentioned the phytocannabinoids, meaning from the plant. Endocannabinoids are what we produce. And these endocannabinoids interact with specific receptors that are found on neurons and on our immune cells. And what they do is they act to reduce excess nerve activity and suppress inflammation. The endocannabinoid system functions in conjunction and in parallel with other nervous systems in our body. So that's just a high level overview. And then the three main components of the endocannabinoid system include our endocannabinoids, which I talked about us producing. These are termed anandamide and 2-AG. And then we have receptors and we have enzymes. So these endocannabinoids are produced on demand and then broken down after they're used. So these enzymes help produce and break down. And that's essentially what the endocannabinoid system consists of. So just to drive the point home, we have the phytocannabinoids that come from the plant and the endocannabinoids that we make. So this is what the human endocannabinoid system looks like. In terms of, we have receptors called CB1 and CB2 that the cannabinoids, either from our body or from the plant, will bind to. And so the CB1 receptors are mainly found in our central nervous system here in the brain and down our spinal cord. And the CB2 receptors are found mainly in the periphery of our body. And they exert a number of different effects, too much to really touch on in the scope of this talk, but just know that there's a lot of different effects that I'll talk about some of the more major medicinal effects in upcoming slides. So this was a survey that was done in California dispensaries in 2011, basically just surveying patients who were coming into a medical dispensary and asking them what they were using cannabis for. The vast majority reported using it for pain, and closely followed by things like sleep and relaxation. And then further down the list, muscle spasms, anxiety, appetite stimulation, nausea, depression. So it's very wide ranging what people find it useful for. Some of the potential therapeutic benefits of cannabis are listed here. What I can tell you is I see it mainly, I use it mainly in my practice for things like nausea and vomiting. A lot of my patients on chemotherapy experience this symptom, and they find the cannabis to be very helpful. Anorexia and cachexia simply means, loss of body mass and loss of appetite. And so that patients do find this to be very helpful for stimulating appetite, AKA giving them the munchies, and things like pain as well. So those are the major effects that I will utilize cannabis for. So THC, in case you don't already know, it is the intoxicating ingredient, is an intoxicating cannabinoid. So we have to be very cautious when we're utilizing it for medicinal values, because we do have that rate limiting step. We don't want to go into that area where it's intoxicating the patient. The vast majority of patients who want to use cannabis because they're sick and don't feel well do not want to get high off of it. So I tell patients we're trying to look for this therapeutic window in which we will find, hopefully, that therapeutic benefit we're looking for without going into that intoxicating area. We want to stay in that sub-intoxicating zone. So that's important to note, that too much THC will have a psychogenic effect and cause someone to feel high. Additionally, it can cause things like fast heart rates and maybe lower the blood pressure. So we want to make sure that the vital signs are good and the patients aren't unstable in any way in terms of their hemodynamics. But the major things that I'm using it for here: analgesia or pain relief, as an antiemetic or nausea and vomiting suppressor, and appetite stimulation. Some of the major effects of CBD. So CBD has a big name in the anti-epileptic world. So it is utilized for, it was made into a drug by the FDA a few years back called Epidiolex. And it's really, really high dose CBD at a very hefty price tag as well. But it was recognized that CBD does help to suppress those excess neuron signals, as I talked about before with the endocannabinoid system, but they really exploit that with the high doses of CBD to help with epilepsy and some pediatric conditions. But I digress. So CBD is used as an anticonvulsive, yes. It also can help with pain. The thought is, as it's an anti-inflammatory, that in that respect, it can help with pain. It helps with anxiety and maybe some depression as well. The data to support those are not very strong, but I can tell you anecdotally, lots of patients do find it to be relaxing and help with anxiety and sleep. It's important to note that we do have some cannabinoid medicines already out there. So I want to touch on this so that we're aware of that. So dronabinol, or otherwise known as Marinol, you may have heard of. It's a Schedule III drug on the DEA classification. It has been approved since 1985 for chemotherapy-induced nausea vomiting, as well as for AIDS-related weight loss. It is not herbal. So it is synthetic. So the THC, it's basically a synthetic THC, is not from the plant. It is made in a laboratory. So I always make note of that when patients are using it. There's some benefits, but there's also some drawbacks. The benefit is that it is covered by insurance. Once the insurance approves it, it can be picked up from their local pharmacy. And so access to it is much easier than having to go through the New York State program and obtaining it through a dispensary and paying out of pocket for it. So that's definitely a pro. The con is that, it doesn't have the other elements from the plant. And I find that patients may even find some more side effects from its use because it's not balanced out by the other elements, like the CBD in particular, that you get from the cannabis plant. Nabilone or Sesamet is also a synthetic THC that's approved for chemotherapy-induced nausea vomiting. Same issues with dronabinol, it's a synthetic. Nabiximols is not FDA approved here in the United States. However, it is approved in 10 countries for spasticity and neuropathic pain and multiple sclerosis, as well as intractable cancer pain. It is a cannabis-derived liquid extract from 2 strains of cannabis, sativa, and it's an oral mucosal spray, so patients can spray it into their mouths. But again, it's not utilized here in the States. I make mention on this slide of a medication called rimonabant. So the thought was, if you bind the CB1 receptor and create an increase in appetite, the reverse should be true as well. If you block the receptor, that you block the appetite and thus have potentially something to help with obesity and overeating. It didn't go well. So when you block the receptor, it's not as straightforward, because we know that the cannabinoid system functions in many different ways. It affects many different pathways. And so it wasn't as simple as just blocking the appetite pathway. It actually caused some very serious psychiatric effects. So it was taken off the market. So it just speaks to the complexity of the endocannabinoid system. The entourage effect, it's important to make note of, and this is kind of why I'm biased towards using the plant-derived medicine versus a synthetic like the dronabinol, because the entourage effect is this overall enhancement of the cannabinoid effect by non-cannabinoid components. So the other elements that are taken out of the plant. If you remember, one of the first slides I showed the different biological components, which included the terpenes and the fatty acids and vitamin E, all these different things that come along with the cannabis. It creates an overall more beneficial effect. So they call that the entourage effect. Some important factors to consider when we're talking about how cannabis may influence a patient. We of course want to talk about the dose. That's important. We dose in milligrams as we would any other medicine. So that's one of the more important things to talk about, because I don't want patients starting out on 20 milligrams THC. That would be really detrimental. The ratio of the various cannabinoids. So I'll show you a slide that'll make more sense. But we have CBD and THC, are 2 major cannabinoids, in a proportion to one another. So what kind of ratio is it going to be? Is it going to be a balanced ratio, a CBD predominant ratio, THC predominant ratio? So that's important to consider. And what we take into account is various factors. as well as what we're trying to achieve. What's the goal of the cannabis for this particular patient? How they're taking it. So if we are inhaling it in a vape, it's going to kick in very quickly. If you eat it in a gummy, it's going to kick in much more slowly. And then also how long it stays in the system is dictated by how you take it. Or the overall age and health of the patient, any other their past experience with it. I may have patients who are walking in having never used cannabis versus patients who have used it every day for the past 40 years and now they want to get it legally. So very different types of patients. You have to consider their tolerance levels and what other drugs they're taking, right? So we want to make sure that patients are not using things that are already sedating them, and then we're adding cannabis to the mix, and how will that be received? All right. Any contraindications? Well, the absolute contraindication that I really have a hard stance on not putting patients on cannabis is for unstable psychiatric illness. THC may provoke a schizophrenic break in somebody if they're predisposed to it. If they have already a history of psychosis, it may make matters worse. So even if a patient tells me, yes, I have a history of schizophrenia, it's stable, I'm on the medications, and I'm already smoking marijuana, I would not feel comfortable contributing to that. So they can do what they want on their own, but I'm not going to necessarily recommend they use it on a medicinal level, doctor recommended or anything like that, if it may make their psychiatric illness more unstable. That's really the only absolute contraindication. Relative contraindications, you want to make sure that their cardiovascular health is good. If they have like an unstable arrhythmia, you wouldn't want to make that worse with the THC. Or, if they're in kidney failure or liver failure, that affects, metabolism of all drugs. So those are things to keep in mind. And then pregnancy and breastfeeding. So we know that THC can affect neural development. So that's why we don't want adolescents using it. We don't want developing brains, using cannabis, THC. So certainly we don't want the fetal development to be affected, either in utero or through breastfeeding. So those are relative contraindications, always weighing risks and benefits. Some side effects of cannabis use include distorted perception, loss of motor coordination. People can have difficulty concentrating. Basically, if you know what it's like to be high on THC, these are all the side effects. Dry mouth is something people will report even, in sub-intoxicating doses. I have patients who will get dry mouth after using their medical marijuana. It's usually something that they can tolerate. Cannabinoid hyperemesis syndrome is talked a lot about in the media, and you'll hear things along those lines when people are trying to make an argument against cannabis. I can tell you that people who use it medically, I've been doing this for about 6.5 years now. I've never seen a patient present with cannabinoid hyperemesis syndrome, meaning that it's like this repeated daily nausea, vomiting. When they're using it in a medicinal way. It's usually seen in patients who are using it in a recreational format in very high amounts every single day. And there's a really easy cure for it. They just have to stop using marijuana. But it's not something that we typically see with medical marijuana users, who tend to be using it in much more controlled doses in lower amounts. And of course, I counsel about driving. My patients, can they drive while they're using medical marijuana? In many circumstances, they can, but we want to be sure when we're first starting out that we're experimenting with dosing, in an evening time or times when they're not going to be driving, and that people execute a very, very good amount of common sense, just as they would with any other controlled substance. So where is the data moderate to strong? So we have good data to say that cannabis can help with epilepsy, as I talked about Epidiolex, the CBD medication, neuropathic pain, so nerve pain, tingling, numbness, burning, and multiple sclerosis. So data is moderate to strong in these areas. We do not have compelling data for things like appetite loss, acute pain, anxiety, insomnia, mood disorder, glaucoma, opioid use disorder. These are areas where patients will use cannabis, but it's just that we don't have the good evidence for it. Unfortunately, it doesn't mean it doesn't work. It just means that the studies haven't been either done or sufficiently done to prove it. I want to talk about the New York State program because I'm sure people have a lot of questions. So in June of 2014, then Governor Cuomo passed the Compassionate Care Act, which effectively started the chain of events leading to opening the medical marijuana program in New York State, which launched on January 7th, 2016. What we had at that time was 5 registered organizations that were approved to grow, manufacture products and sell them in dispensaries across the state of New York. Each organization was allowed to have 4 dispensaries. So in effect, 20 dispensaries for the state of New York. In August 2017, they doubled the amount of dispensaries by adding 5 more registered organizations, each allowed to have 4 dispensaries. So where we stand today is probably, give or take a few, about 40 dispensaries across the state of New York. It's important to note this is an out-of-pocket expense. Insurance does not cover it. It is a Schedule I drug. As of right now, the federal government still views cannabis as an illegal substance that it has no medicinal value. So what are the qualifying conditions in New York State? They are listed here. Initially, we had 10 qualifying conditions. More were added as time went on. But in January of 2022, they revamped the program in preparation for the recreational program going live. And basically, any practitioner, any healthcare practitioner who is registered with the medical marijuana program in New York State can put a patient on cannabis if they feel in their clinical judgment the patient would benefit. So there is literally a write-in, we can write in the qualifying condition that we believe would help a patient. So we're no longer held to just this list. And what are the approved modes of administration? So basically, I feel like every week there's new formulations coming out. Initially, we had 3 formulations in the first year. We had vape, like in a vape pen, capsules, and a tincture or an oil, like a liquid. Those were it. We had 3 options. And then as time went on, they really started to diversify the product line. And now we have them in many different ways. You can buy the flower to smoke. Edibles are where it's at. Everyone's coming in asking for gummies these days. And there's even suppositories, rectal, vaginal suppositories. So people are getting creative with, how to take it, and topicals as well. I was waiting for a while for topicals. I think they came out in 2019 or something like that. So it was about 3 years before we were able to use it in a cream, which is nice because a lot of patients do find it to be helpful for localized pain or like burning, neuropathy in the feet. So it's important to know, as I said earlier, I alluded to earlier, that how you take it dictates how long it takes to kick in and how long it stays in your system. So for example, an oil that's absorbed up in the oral mucosa in the mouth under your tongue, we should kick in rather quickly. I think 30 minutes, I got this from a paper, but I think it's even quicker than that. My patients will report feeling something in about 10, 15 minutes usually, and it lasts somewhere around 4 hours. So you can redose it during the day if needed. Vaporized is immediate. So if you inhale it or you vaporize it, it goes into the bloodstream through the lung capillaries. And so it really goes in very quickly. And it typically lasts a couple of hours. 4 hours is quite generous, but it's usually 1 or 2 hours. And so I'll have patients who, if they prefer to inhale, they can carry their pen with them and inhale throughout the day, a dose of medication. And capsules are much longer. So, I don't typically start patients on capsules because it's when we're trying to figure out the right dose, we don't want to say something that's going to stick around for 8 hours. We rather have something a little more short acting, and also be able to change the dose with a little bit more ease. You can't do that with capsules. So this is what the spectrum looks like. So earlier I talked about the THC CBD ratio. So this is what it looks like. You have on one end of the spectrum a THC dominant formulation, on the other end of the spectrum a CBD dominant formulation, and right down the middle we have a balanced THC CBD combination. I typically start patients, for the most part, patients I'm seeing who have similar symptom clusters in the cancer world, and if they haven't been using any cannabis, starting at a balanced ratio makes a lot of sense. So what's next? I mean, here we are, we have 37 states that have approved medical marijuana. Where do we go from here? So certainly doing things like I'm doing now, which is trying to educate the public. I educate my clinician partners, just help to destigmatize. I not only want to educate, but I also want people to, I want doctors to feel more comfortable having the conversation, being able to receive the conversation, not have their patients feel negatively judged because they might be using cannabis. So that's part of my goal. Ultimately, federal legalization will help everybody if we can get cannabis off of Schedule 1 and at least rescheduled to Schedule 2 or 3 and make it hopefully better studied, more accessible, covered by health insurance. That would be better for everybody. And we need more studies. So if we were able to reschedule it, we could study it easier, because studying a Schedule 1 substance is very difficult. There's a lot of red tape. And ultimately, insurance coverage is going to make a huge difference, because there's a barrier to access it if you have to pay out of pocket. That it's sort of a self-selected group of people who can continue to pay for it every month out of pocket. And there are people that just cannot take advantage of it because of that reason. If you want to know more, Cannabis Pharmacy, written by Michael Beck, is a good book to start with. And I'll tell you a quick story about Mrs. B. Mrs. B was one of my first patients I put on cannabis back in March of 2016, when the program had been open only a few weeks. She was, I guess at the time, in her mid-80s and had really bad lumbar spinal stenosis. Caused her a lot of back pain radiating down her legs. She was on a number of different medications that were only doing so much. They were sedating her. She had very little quality of life. So when I was waiting for her to come to the office, I received a phone call from her daughter saying that the patient was actually in North Shore University Hospital's ER. Mrs. B actually took a handful of tramadol the night before in an attempt to take her own life, because she was so miserable from the pain that she was in every day. And so thankfully she didn't have any major harm caused. And she saw me in the office the following week, and we did the certification, and she was actually a little bit knowledgeable already about cannabis, because she and her grandson sometimes vaporized it out of a bong, if you can believe that. So she was no stranger to it, but didn't like the fact that that's what she was resorting to. This felt a bit more prescribed for her. So she got her vape pen, and I followed up with her a month after, or maybe 3 or 4 weeks, whatever it was. And she had just been using it for a couple of weeks at that point, and she was a changed woman. Her daughter was in disbelief as to how much more mobile Mrs. B was, and how happy she was. She was doing a little jig in the house, every day, just sort of so happy that she wasn't suffering and so miserable anymore. Yes, she needed her meds still, like her gabapentin and maybe some other meds, but the additional relief provided by being able to use the cannabis on an as-needed basis throughout the day really gave her such improvement in her quality of life, to the point where now, 6 years later, she still uses it. She's still on, a bunch of medications, and there's other issues that have popped up, just secondary to other medical issues in her age, but she still uses cannabis, and it's been a life changer for her. Not every patient's going to have, such a transformative story, but this one really stuck with me, as she was one of my first patients, and when I was kind of skeptical getting involved with medical marijuana, her story really changed me.
Mm.
So in summary, cannabis is generally well tolerated. It is not something that we have to worry about that this is serious adverse effects when we use it judiciously. And we should be careful using it in patients with psychosis and cardiac disease. But there's good data that shows that it actually is beneficial in things like epilepsy, multiple sclerosis, and neuropathic pain. However, large randomized control trials showing the therapeutic benefit in general are still lacking due to its Schedule I designation. These are my references, and I just want to thank you. And we have about 20 minutes to, address any questions that might pop up. Thank you. I'm going to stop sharing now.
Thank you so much. That was so informative. So there are no questions in the chat, but does anyone have questions that have been on their mind?
Yeah, I have a question. So where do we begin? I have a lot of pain in my legs from the chemo, and I spoke to the chemo doctor and said I don't know anything about that. When I asked about marijuana, where do I start to get help for this?
Okay, so if the oncologist doesn't know anybody who's involved with medical marijuana, sometimes there is a palliative care team, like myself, involved with the cancer center, especially if you're like a larger academic institution. There should be a palliative care team that is knowledgeable in medical cannabis. I can't say that all palliative docs are, but many are. Worst comes to worst, yes, there is the ability to Google and find, sites like, Weed Doc or something like that. I'm not crazy about them, but they are a kind of painless approach to getting certified. They allow for an online consultation, usually like a telehealth appointment with either a doctor or a nurse practitioner or PA who is able to certify patients. I just don't like the whole idea of having to pay, a few $100s for a certificate. Usually the doctors who are involved with it, when they're part of a large health system, do not charge. We do the certification for free. And then, because you're going to have to pay out of pocket for the substance itself. So we prefer for that to be where your money goes. But if the accessibility issue is there, certainly using an online telehealth provider is a way to get onto the program. However, there's also, if you were to Google like the public New York medical marijuana prescriber list, there actually is a public database. I can't guarantee that all the doctors listed there actually actively take patients and certify, but it is a way to sort of narrow down by where you live and specialty of the providers. And you can call the office and see if the doctor takes on any patients for medical marijuana.
Okay, thank you.
Hildred, your hand's up.
Yes, Dr. Martin, I was poised to listen if anything was mentioned on cannabis when it comes to treatment of diabetes. I also thought about, in listening, I think about the many people who have lost their lives or even have been imprisoned when it comes to the use of cannabis. And it caused me to wonder why, through all the ages, wasn't our people educated in the many uses and benefits of this plant? I don't know if you could shed any light on this. I would be glad to listen.
Yeah, thank you, Hildred. So first off, I'll touch on, so diabetes, other than the peripheral neuropathy that we know is associated with diabetes, I don't know of any like of the direct benefits that cannabis can have on diabetes. Unfortunately, it's outside of my scope. The cannabis is implicated with many potential or purported benefits. And I think I've seen diabetes on there, but I could not speak to how it affects that pathway. There is so much research going on in the cannabis world. I wouldn't be surprised in the next decade if we heard of some potential benefits associated with the plant and diabetes, but other than neuropathy, as far as the symptomatic benefit, I couldn't speak to anything more. You know, as a palliative care doctor, our focus being quality of life, cannabis fits hand in hand with focusing on helping improving quality of life. How does it affect overall pathology of different disease states? That remains a question that needs to be answered. As it pertains to disparities in racial and ethnic disparities in cannabis, it's a huge topic. And so as I noted earlier on, you know, with the Marijuana Tax Act that was passed in the 30s, I'm sorry, the propaganda campaign was in the 30s, and then it was pretty much banned and removed from the pharmacopoeia. It was very racist. So I think from that point on, and you know, I think we can go on a divergence here, but you know, knowing how this country was sort of founded on so many racist beliefs, it's not surprising to me at all how marijuana stayed with this stigma over it for so long. And so yes, we have a lot of people who I know that now with legislature passing, and at least in New York State, with trying to legalize it and stop putting people behind bars for petty crimes with having to do with marijuana, and releasing people from jail who have been behind bars. I think there's still so much more work to do, but it's no surprise to me that there's this disparity still. You know, when we have this higher class of people, right, using it for all sorts of we have these dispensaries that are very foofy now, and it's all legal, but you still have Black and brown people behind bars. It's a major issue, and I think one that we need to work on, and not just on the state level. But again, we need federal legalization before we can really see some major changes happen. It's a big problem, though.
Thank you.